to the answers. Able to see the slides?
Yes, sir.
Okay. So we have a 6-month-old baby posted for circumcision, recently recovered from LRI. Okay. So what further information is needed for you in this case? Supposing they just give you this scenario, 6-month-old male baby posted. What is the indication for circumcision?
So it could be active, or also it could be because of retracted prepuce with recurrent UTI, pain and swelling. So it was not mentioned.
Mainly phimosis. Okay, it is done for phimosis, which may be because of the symptomatic phimosis causing obstruction and passing a free stream of urine, or it may be a religious circumcision. Some, as you all know, Muslims do circumcision for kids as a part of their religious ceremony. So circumcision can be either religious or for therapeutic reasons. For phimosis, that is tight foreskin or preputial skin. So first information you need is whether it is a therapeutic or a religious circumcision. Anything else you want to know for this 6-month-old baby? What other further information you need?
Whether it is breastfeeding or
Preterm or term baby.
preterm.
Birth history. Always when you get a pediatric patient less than 2 years old, always ask for the birth history first. Was the child born at full term? Was it born by natural vaginal delivery? Or was it born by cesarean section? Or was it a premature baby? As you rightly said, if there is a history of prematurity and the child at 6 months comes for circumcision, what is the important risk you have? And you have been concentrating on giving GA.
Poor reflexes.
Poor reflexes.
Premature.
Poor reflexes.
I mean, poor development.
Decrease in FRC.
Supposing this child is born at 34 weeks and then nurtured in the neonatal ICU, taken care of and grown, and now has become 6 months, and it has got a tight phimosis, and they want to do a circumcision for this child. What is the importance of a premature birth and a GA in a recently after birth?
So immature GI system, and so metabolism will be slow.
Now the child has to come out of that. It is born. It is now 6 months after birth. You think still the metabolism will be there? What is apnea of prematurity? Have you heard of the term apnea of prematurity?
Yes, sir.
Yes,
What is that? Children who are born as a premature baby, if they undergo surgery within the first 6 months of their postnatal life, they are prone for a condition called apnea of prematurity, where even after recovery from general anesthesia, in the post-operative period, they may go for a spell of apnea, resulting in desaturation and bradycardia and sometimes even cardiac arrest. Okay?
Yes.
So these babies who have a history of premature birth should be very, very carefully observed, especially during the first 6 months of their post-birth life. If they come for surgery, they must be very, very carefully managed by a continuous pulse oximetry, and the ward sisters or the attenders who are looking after the baby should know that there is a condition called apnea of prematurity, and baby can suddenly stop breathing. At the time, what you have to do is just stimulate the baby and make it breathe again. And that if you miss that, patient can go in for desaturation, which will result always in bradycardia and arrest. Why they go in for bradycardia when they desaturate? These
They
small
have
infants.
Heart rate dependent hypoxia, sir.
sympathetic
Heart rate
system was
dependent
not
hypoxia.
very. They have
Hmm?
a prominent parasympathetic.
Sympathetic system is not well developed until the age of 3 years. So they have a predominant parasympathetic activity. So any desaturation, they always go for bradycardia instead of tachycardia. So they will always have a predominant parasympathetic activity. So you have to be very watchful. Is there any drug which you can administer to prevent this incidence of apnea of prematurity occurring in the immediate post-op period?
Caffeinated drugs.
Caffeine, caffeinated, nothing, nothing called caffeinated. There is a
Caffeine drugs.
caffeine is available as a syrup as well as drug. 20
Yes.
milligram per kg of caffeine given pre-operatively 4 hours before surgery will prevent. It is a stimulant, so it will keep the respiratory system stimulated and patient will not go in for apnea. Okay, it is a central effect, so it will have to be corrected by giving caffeine 20 milligram oral
Yes, sir.
for surgery, or otherwise the best thing is to watch them for apnea in first 24 hours. It is very, very common. So they have to be continuously monitored with a pulse oximeter, and not only monitoring the people attending on the baby, whether it is the attenders, the family members, or the staff nurses or the paramedical personnel, whoever is looking after the kid, should be watchful to see whether any prematurity of apnea of prematurity is happening and correct it immediately. That is number one. After the birth history, now what other information you would like to get? I've
Developmental
forgotten to put the
milestones.
animation in the screen. So all the questions are there, and the clue is there in the screen itself. In all pediatric patients, what important information you want?
Developmental milestones, weight gain.
You see a chart here. What is this?
Whether the baby is
Pediatric?
appropriate
Weight.
as
Pediatric
appropriate
weight,
for
yeah, you must know the exact weight of all the pediatric patients more than the adult patient. Why pediatric patient weight is very, very important?
So we have to give the drugs according to the weight of the baby.
So if you don't know the weight, you are likely to err on the higher side and give a higher dosage, which may be toxic to the baby. So all pediatric patients, you should have the correct weight measured and compare it with the expected weight for the age. So how to calculate? This is a very common question asked in the examination. How will you calculate the expected weight for the age? For that only I have got given those 4 formulas here. And the commonly used formula is Weech's formula, where for 3 months to 12 months age, it is age in months plus 9 by 2. This is the formula that you have to use. So for example, if the 6-month-old baby weighs about 5 kilos, is the weight correct or underweight?
Underweight, sir. It
It's
should
underweight
be
baby.
approximately
Okay, it should be
7.5.
roughly 7.5 kgs. Okay, so by calculating the expected weight and comparing with the actual weight, what is the inference you will do?
Malnourishment.
Nutrition, whether the child has received adequate nutrition or not. Okay, so always you must compare the expected weight with the actual measured weight, and it will give you a clue about the nutrition, whether the mother's feed has been given properly, whether the child has been taking feeds properly. If the child has been repeatedly falling sick with LRI, URI, it will not have sufficient weight gain. And if there is no sufficient weight gain or the expected weight is not matching with the measured weight, what is the problem in that? If the nutrition is poor, what is the problem?
Failure to thrive.
Post perioperative infection is more common.
The child is more prone for infection. Immunity will be very low in those children. Okay, that is why they fall sick very often. So they can catch a post-op infection. The wound healing may be delayed. So this problem also can happen. So the first thing you want is the birth history in all pediatric patients less than 1 year. Second is the weight and match it with the expected weight using the formulas that are given here. And the third thing is they have given you already patient has recently recovered from an LRI. Okay. So how will you know it is only LRI and not URI? What questions you will ask the informant to find out whether it is LRI or URI?
Baby is feeling difficulty while sleeping, sir.
What difficulty?
Repeated cough.
Coughing, yeah. So URI mostly produces running nose and watering eyes and stuffiness in the nose. But LRI produces cough. So it may be, especially if it is a wet cough or a purulent cough, that indicates there is a severe infection in the lower respiratory tract and not merely the upper respiratory tract. Second thing is, whenever a child gets an LRI, will it be very active?
No, sir. It will be lethargic.
It will be lethargic, less active, tries to be dull all the time. How will the appetite be? Will it be
Reduced.
eating well?
No, sir.
It will refuse feeds. Okay.
Yes,
So
sir.
will it have a temperature? Increase in the body temperature, fever? Yes, fever also will be there. Why so much time? So the indications of an LRI are one, cough, which may be initially dry, going on to become wet cough. Second thing is the patient looks very dull and lethargic. The patient may have spikes in temperature, fever will be there. And fourth, the patient refuses feeds. So these four things indicate it is a classic LRI, which is mostly, what is the etiology of LRI in small kids or infants?
So it's usually bacterial, sir. If it is URI,
Streptococcus.
it will be viral.
Viral, which secondarily infected by bacteria. If not corrected or treated early, usually it starts as a viral, then goes on to have a secondary bacterial infection. Okay, so it should be treated at the earliest stage so that it can prevent a bacterial infection setting in, especially in the scenario of a reduced nutrition and immunity. Okay, so these are the three things that you want to know as a further information. One is birth history, the second is the weight gain according to the age, third is the nature of LRI, whether the child had fever, whether the child had cough, whether the child had lack of appetite, whether the child was listless. All these questions should be asked and confirmed. Then treatment history. How the LRI was treated, because it is given here recently recovered from LRI. That means now the child is free from the lower respiratory tract infection. So what is the treatment that was adopted? Was the child taken to a pediatrician and given some antibiotic, any nebulization, any steroid, any cough suppressants? All that history should be asked. And whether the treatment is being now continued or whether the treatment has been already stopped, because recently recovered means maybe still, usually the child having an LRI is taken to the pediatrician. After treating it for 4 or 5 days, he will just say, yes, the child is fit, you can take it to the surgeon and show him and get him operated. So there you do not know whether the child has fully recovered or not. It is the pediatrician's word that he says the child is fit now, you go and take it to the surgeon. So how to find out whether there is any residual infection? Because apparently the child's cough has come down, fever is not there, child has started eating. But if you probe and ask, the mother will say occasionally there is some cough, but not like before, it is not that frequent. So how will you as anesthetist confirm that the child has recovered completely from the LRI? Any particular method of examination to find out any residual infection is there in the lungs or not?
Sir, examination of throat and auscultation.
Simple auscultation or any special type of auscultation? Auscultation everybody does. The pediatrician also would have auscultated and said lung is clear and you take the baby for surgery. But as an anesthesiologist, do you have any special method of auscultation to find out whether there is any residual infection in the chest or not?
So I can ask the baby to close the mouth and cough. And
6 months old baby will be able to understand what you say and do it.
no, sir.
Must always look at the case scenario. It is not an older child to understand what you say and comprehend and follow your instructions. How will a 6 months old baby will be able to understand if you say close your mouth and try to cough?
Yes, sir.
What is post-tussive auscultation? Have you heard of the term post-tussive auscultation?
Yes, sir.
Yes, sir.
What is that?
After coughing,
Conductive sounds will be cleared off after coughing up.
So how will you make a child cough? 6 months old baby, if you say, come on baby, cough, will the baby do a coughing?
we can pat the baby's backside and to
By
clear.
patting, you will be only suppressing the cough. Normally, when the baby coughs, you pat in the back and the cough will come down.
We can make a gag reflex and
Gag reflex. Okay. How do you make a gag reflex? Open the mouth and put a kuchi inside. Is that the way? The attenders will try to look at you in a strange way if you do that. You can induce cough by stimulating the trachea at the suprasternal notch. You put your finger and then tickle the trachea at the suprasternal notch level. That will induce the carinal reflex. And the child will cough. Any child will cough. That is the easiest method of making a pediatric patient less than 1 year to cough. So that is called the post-tussive auscultation. And after the child, so you auscultate before the cough, you find there is a dry air entry, you don't make out any rals or rhonchi. But once you induce the cough and immediately auscultate, then if there is any residual infection, you can pick up a few rals here and there in the bases. That is called post-tussive cough. And if you find rals occurring after the cough, that means the loose mucus secretions are getting separated and coming out, producing the rals. So there is still a residual infection. That is the good clue for you to advise the baby to wait for some more time till the rals disappear. Otherwise, the respiratory tract will still be very irritable. And if you plan to give GA along with that, you will land up with all the problems. So one of the very important practical methods of assessing the presence of any residual infection, even after the child has been declared recovered from LRI, is what is called post-tussive auscultation. By inducing cough by stimulating the trachea at the suprasternal notch. In children, very, very easy to do this. You just put your finger, the index finger in the suprasternal notch and press on the trachea and move it right and left for 1 or 2 times. Automatically, the child will cough. Next time you get a pediatric patient, even if it is a child with a healthy lung, you try to do that immediately. You can induce a cough in the baby. Okay, so
Yes,
that is a very, very common, useful test in all pediatric patients. Next to the discussion, we are going to have the lip and cleft palate. So this is the test I used to do routinely in all pediatric patients to elicit the presence of, and I have picked up residual infection in at least 10% of the cases which have been declared completely recovered from LRI, and cancel them or postpone them till they completely recover. Okay, and you can sometimes hear a very wet cough itself when you do this post-carinal stimulation test. So these are the 4 things that you have to take care of. One is birth history, second is the weight gain, third is the nature of LRI that the child suffered, and fourth is identifying the presence of any residual respiratory infection by doing post-tussive auscultation after stimulating the what is called the carinal stimulation at the supraspinal notch. So these are the further information that is needed. Now, of course, the second question, how to calculate the expected weight for the age, you have this is also the common question, as I told earlier, by the examiners. So you can remember any of this formula, whether it is test formula or weak formula, simple. For older children, you can use this hand. Age in years, 1, 3, 5 odd numbers will be 10 kg for 1 year, 15 kg for 3 years, 20 kg for 5 years, 25 for 7 years, and 30 for 9 years. So one age increases by 2, the weight increases by 5 kg. This is a very simple method or rough method of calculating. But if the baby is less than 1 year, you have to go for this particular calculation. 3 to 12 months, age in months plus 9 by 2. So that is this formula you can use. Now, how to completely assess recovery from recent LRI, as I told you, by the post-tussive cough. And what is the preferred anesthesia for this child? So the basic goal, whenever a child has recently recovered, even if it is totally recovered from the LRI, it is always ideal to go for a regional technique without resorting to any airway manipulation. So what is the best regional technique you can think of?
Caudal epidural.
Caudal epidural, excellent. So caudal epidural is the preferred method of anesthesia for circumcision surgery. Now, a child of 6 months, will it cooperate for giving caudal if it is fully awake and conscious?
No, sir.
No,
No.
sir.
So you have to give some form of sedation, isn't it, to achieve a good caudal block. So how do you sedate the child? And as Vidya said, 6 months old, the child may be having stranger anxiety or separation anxiety. That is the transitional age. Roughly around 5 to 6 months, they start recognizing people and they may develop stranger anxiety or separation anxiety. So to abolish the separation anxiety as well as to make the child cooperative for the caudal block, which will be the best form of sedation that can be given without using the respiratory system of the child.
So we can ask the mother to accompany.
So if the mother is accompanying, will the child be quiet when you give a caudal block? Mother will faint and fall down if you do a caudal block with the mother accompanying the child.
A combination of midas, ketamine with glyco dose can be.
So we
Midas,
can go with ketofol, sir.
ketofol, which route?
Yes.
Ketofol, is it given intramuscular or
IV.
intravenous?
IV.
So first you
Or
have to
IV
secure.
ketamine.
The best thing is to give what is, have you ever heard of stunning dose of ketamine?
0.5 mg per kg ketamine IM, sir. 30 minutes. 15 to 30 minutes.
Ketamine, there are different doses. what is called sub-anesthetic dose and anesthetic dose. What is the normal anesthetic dose of ketamine?
1 to 2 mg per kg intravenous.
Intravenous. If intravenous access is not there,
1 to 2 mg per kg intramuscular.
1 to 2
3
is
to
it the
5.
anesthetic dose?
Up to
3
4
to 5
milligram
mg
per
per 3 to
kg
5
IM
mg
dose.
per kg IM, sir.
IM is 5 to 10 milligram per kg. Anesthetic dose of ketamine is 5 to 10 milligram per kg IM. IV route 1 to 2 milligram per kg. Okay. But if you give this 5 to 10 milligram per kg, you can even finish off the surgery with that, because it is a good analgesic, and surgeon can easily come. A fast surgeon doing it as a guillotine procedure can easily finish it off within 5 minutes time. It can be done. But to go for a caudal block, you have to give what is called a stunning dose, which is 2 to 3 milligram per kg IM. In this dose, the patient will just go for this dissociative anesthesia. It will not go for a complete anesthesia as you expect with a full dose of 5 to 10 milligram. And the patient will not have the separation anxiety. It will have a staring look, and it will be able to tolerate even a IV venipuncture, and it can tolerate a caudal block also. All the needle pricks that happen because of when you do a venipuncture as well as caudal block, all that can be tolerated by the child if you just give 3 milligram per kg IM and wait for about 10 to 15 minutes. So once you give this 3 milligram per kg, how do you know that the effect has come on, and when will you try to take the baby from the mother? Because if you just inject 3 milligram per kg, for example, this child is weighing 7 kilos and you give 20 milligram IM, can you immediately after injecting and taking out your syringe take the baby away from the mother?
No, sir.
So how do you know that the effect has onset has happened and you can separate the baby from the mother? What is there any clinical indicator for that?
Eyeball movement.
What do you call that? Eyeball movement.
Nystagmus, sir.
Nystagmus.
Nystagmus.
Yes.
Horizontal.
Ketamine intramuscular always produces nystagmus at the onset and nystagmus at the offset. Both during onset and recovery, you will find the eyeball having nystagmus. What type of nystagmus will be there?
Horizontal nystagmus.
Horizontal nystagmus. Yes. So it is right to left movement. That is called horizontal nystagmus. If it is going up and down, it is called vertical nystagmus. So you will find the right to left movement, which is horizontal nystagmus. So after injecting the drug, you have to wait for about 5 to 10 minutes and keep looking at the eyeball. Once the eyeball starts having the nystagmus movement, that means the effect has started. Then you can separate the baby from the mother. It will not cry, it will not make any ruckus, and you can easily take the child inside, and you can even start an IV line, or you can even give the caudal block straight away with this analgesic dose and proceed with the surgery. Now, once you have sedated the child and given the caudal block, how do you know whether the caudal block is effective or not? You cannot allow the surgeons to start the surgery and child flexing the limbs and wriggling with pain, and you cannot have that sort of clumsy situation. So how can you confirm that your caudal block is effective under sedation with ketamine, or even if you do inhalation induction and then give the caudal block, whatever method of sedation you have achieved? How to confirm whether the caudal block is effective for this surgery or not?
Involuntary passage of urine.
Involuntary passage of urine. If the child has already passed urine just before coming to the theatre, will it pass again? Or will all the children have incontinence and pass urine? Which are the segments you are trying to block by giving caudal for
S2
circumcision
to
surgery?
S4.
Huh? Which nerves do you have to block for
S2
circumcision
to
surgery?
S4.
Pudendal nerve.
Pudendal.
Segment mean you must always tell the root value. S2, S3,
S2 to
S4,
S4.
sacral segments. Okay. So, apart from the penile skin, what other skin is supplied by this S2, S3, S4 segments?
Anal sphincter, sir.
Anal sphincter.
Cremaster.
Male child, more easily to
Cremaster reflex.
cremasteric reflex. Very good. So, how will you elicit a cremasteric reflex?
By stroking the underside of the scrotum, usually there'll be a contraction of the.
You don't have to
Stroking
go and
is
stroke
inner
the
side of thigh.
inner side of the thigh. Okay, by
From inside
stroking
to
the
outside.
inner side of the thigh, if the scrotal skin contracts, that means the cremasteric reflex is still intact. That means the block is still not effective. On the contrary, if the block has become effective, when you stroke the inner aspect of the medial aspect of the thigh, the scrotal sac will not contract. It will be hanging loosely. So that is the best method to find out the effectiveness of your sacral block under sedation in a male child. I always used to ask, supposing it is a female child coming for a herniatomy, where there is no scrotum, how will you assess the efficacy of your caudal block? If you give a caudal for a herniorrhaphy in a female child, this is where Vidya's answer comes all good. So if you lift the legs and see the anal sphincter, the anus will be lax. It will not have the usual contractions. Okay, if you stroke at the around the anal sphincter will not contract. So in female, you can use the anal sphincter, absence of anal sphincter contraction as an indicator of the effective block. For a male child, male patient, you can use the cremasteric reflex as the indicator of an effective block. So all of you, when you give a caudal block for circumcision, always elicit this reflex, make sure that the block is effective, and then only permit the surgeon to even paint the child. Otherwise, sometimes the caudal takes at least 5 to 10 minutes to become totally effective. And if you allow the surgeon to paint before that, the child may get stimulated at the time, and then under ketamine, it may start behaving in a delirious way. So always you make sure that the block is effective by eliciting the cremasteric reflex and finding out whether it is totally abolished. Then you allow the surgeon to proceed with the painting and draping and surgery. Then there will not be any problem. But giving this small stunning dose of ketamine, how long the child will be cooperative and sedated?
30
the
to
duration?
30 to 40 minutes.
15 to 20 minutes maximum. After that, supposing the surgery is continuing, how to keep the child correct? Your surgeon is a very, very sophisticated plastic surgeon who may take 45 minutes to 1 hour to do a very artful circumcision. In that case, how to keep the child quiet for the duration of the surgery?
Sir, we can give inhalational through face mask or IV. We can maintain sedation with IV also. IV. Okay. So these are the two options. You can just put a face mask and tie it up around the face and give just oxygen and nitrous oxide 50%, which will make the patient remain quiet for the entire duration of surgery. Or you can just give intermittent doses of propofol, 1 to 2 milligram, not on the body weight basis, just as a IV sedation throughout the procedure.
and that will also keep the baby quiet. So this will be the most safest method of anesthesia, where you will have adequate cooperation from the baby without any struggle, and at the same time you can have a very effective analgesia. Is circumcision done as a daycare procedure or is it a inpatient procedure?
Daycare procedures.
Daycare procedure. So what is the role of any adjuvants in the to the local anesthetic block or caudal block?
Since it is a daycare procedure, we can avoid the
Can avoid, but
giving
suppose
adjuvant.
you want to have a prolonged pain relief post-op, parents are insisting that make sure my baby does not have pain for even after the surgery. If they request like that, what are all the drugs that can be added which can prolong the pain relief?
So we can add clonidine or fentanyl.
Can the same ketamine be added to the local anesthetic?
No ideas.
No idea. Anybody having any idea about ketamine added as adjuvant to local anesthetic?
No,
If
sir.
at all, what type of ketamine you can add? You can add ketamine 1 milligram per kg body weight to the local anesthetic as a preservative-free ketamine, not the vial ketamine which has a preservative, methylparaben. But the ampule ketamine that comes in ampules of 50 milligram per ml is a preservative-free preparation. So you can add that ketamine 1 milligram per kg body weight. Supposing the child is 7 kg, you can add 7 milligram to the local anesthetic and inject it. That will give a effective post-op pain relief for 6 to 8 hours. Okay. By the time you can supplement with oral painkillers like paracetamol or ibuprofen and manage the post-operative period. Now, the other common question is, if you are planning to give a caudal block, how do you calculate the dose? What dose and what preferred local anesthetic for the surgery?
Green Armitage formula, sir.
According to
Modified Armitage formula.
Okay. How much? What is the formula? Name is okay, but I'm asking the dosage.
sir,
The drug
we
selection
usually
and the
use
dosage.
0.25% bupivacaine. Since it is a perineal surgery, we can give 1 ml per kg of 0.25% bupivacaine.
Is it 1 ml for perineal? 0.5 is the
0.5
minimum.
ml per kg.
1 ml is up to the umbilicus. If you want T12 level block, you can give 1 ml.
Okay.
But perineal and the sacral block, 0.5 ml per kg is more than enough. And preferably nowadays, because levobupivacaine is available, that will be a better choice than simple racemic bupivacaine. What is the difference between a racemic bupivacaine and a levobupivacaine?
So it is the
Bupivacaine
isomer
has-
different, sir.
It is less
Bupivacaine,
cardiotoxic.
it is levorotatory, so it is less cardiotoxic, sir.
Very good. So the racemic bupivacaine, which was invented and marketed first, has got both dextro and levorotatory isomers of bupivacaine, and it is more cardiotoxic if the dose is exceeded or if it is injected intravascularly. So to make it less toxic, they have separated the levo isomer and make it as levobupivacaine available, which is less cardiotoxic and easily reversible even if there is a cardiotoxicity effect. Why the cardiotoxicity of bupivacaine is more dangerous than lignocaine?
So the dextro isomer gets attached to the cardiac sodium channel, and the recovery from the sodium channel will be very slow. So they are more cardiac toxic. So that's why they changed to levorotatory, which is less recovery will be more rapid.
Okay. So if at all you have used racemic bupivacaine and there is a unfortunate incidents of local anesthetic toxicity. The patient has gone in for bradycardia. How do you resuscitate the child or any patient with a bupivacaine cardiotoxicity? What is the preferred reversal agent that you can give?
So propofol or intra.
Propofol.
First,
Don't answer propofol as the first in the exam.
airway breathing
We
circulation.
have a specific drug. I am asking about the reversal agent which can
Intralipid
recover
emulsion, sir.
intralipid. What percentage of intralipid? See, these are all the
20%.
questions that you have to expect if you get a pediatric case, if you are going to talk about the caudal. These are all the questions which can offshoots from this topic. Okay, so you must be having a overall knowledge of local anesthetic agent, the toxicity, the technique of caudal block, the complications of caudal block, because all of you will not be asked the same question. So the examiners would like to ask different questions to different candidates. So the overall idea, if you have, then only you can manage the viva part of it. Okay, so you must think in that line and prepare your answers when you are preparing for this the exam. Okay.
Yes.
So intralipid 10% or 20%?
20%, sir.
20%. Very good. So this 20% intralipid, was it marketed for treating bupivacaine toxicity?
It
No. It was
no,
considered
sir,
as
for
a
Marketed for a
lignocaine.
lignocaine toxicity.
total
Lignocaine.
parenteral nutrition.
Okay.
Originally, it is a lipid preparation marketed for as a part of total parenteral nutrition. And they found that it is helpful in reversing the cardiotoxicity produced by bupivacaine. So how is that achieved? How does intralipid help in reversing the cardiotoxicity of bupivacaine? What is the mechanism?
So lipid sink and lipid.
Become complexes
Because
together
of
and
increased concentration of lipid, because of concentration gradient, it will
Yes.
move from.
So it is more fat soluble. Bupivacaine is much more fat soluble than lignocaine. Okay. So when you suddenly increase the fat load in the blood, the concentration, it attracts the bupivacaine, which is attached to the sodium channels in the cytosolic cells of the myocytes, and removes it from that binding and takes it away into the bloodstream, where it can be taken to the liver and metabolized. So that is the mechanism. Okay, suddenly increasing the lipid load in the blood attracts the lipid soluble bupivacaine and removes it from the intracellular or cytosolic site of the sodium channel and makes it come out of the cell and remove, so that the conduction will be re-established and the bradycardia arrest, whatever has happened, will be able to revive. So even after 45 minutes to 1 hour of cardiac arrest, if you have doing a good CPR and applied, administered intralipid, they have found that patients have completely recovered without any damage to the heart or the brain. And so you should not give up resuscitation even if you encounter a local anesthetic toxicity following by bupivacaine. And if you have intralipid, you must administer it at the earliest. Okay, so these are the lessons that you have to learn from this. Coming to the caudal block, what is the technique of doing a caudal block?
The patient is placed in the lateral position.
Baby
With
lie
the,
in the lateral position. We have
Right
to
lateral or left lateral?
usually left lateral, sir.
Left lateral. So you stand facing the baby's face or at the back?
Facing the baby's back, sir.
Back. Okay. So you must face the baby's back. What is the position of the leg? Is it kept straight or flexed?
Hips and legs should be flexed, sir.
Both hip and knee should be flexed. Okay, just like giving spinal in an adult, where you flex the hip and the so-called fetal position, where you flex the baby. But here you need not flex the cervical area. You can flex only the lumbar and sacral area by flexing the hip under. So how do you identify the space?
So
What
it
are
is
all
the
the anatomical
apex of,
landmarks?
it is the apex of the equilateral triangle where the bases are formed by the posterior superior iliac spine, sir.
What is the nearest anatomical bony landmark for identifying the entry point for the caudal space or caudal epidural space?
Crest. Sacral crest.
Huh?
Sacral hiatus.
Sacral spine is
Sacral hiatus. What
sacral
is
spine.
guarding the sacral hiatus?
Sacrococcygeal spine.
Sacral cornua. They are called sacral cornua. Okay, there are two small bulb-like projections of the sacral bone, which is called sacral cornua, which is connected by a semicircular bone, which is called the sacral hiatus. Okay, and it is covered by what?
Sacrococcygeal membranes.
Sacrococcygeal membrane. Okay, so you identify that space, and then what is the angle at which you will puncture the skin and the sacrococcygeal membrane? How do you do the technique? What is the entry point? How do you use the needle? What is the angle of the needle for entering the caudal epidural space?
Sir, I saw two techniques, sir. Initially, they'll be going perpendicular to the skin. After hitting the bone, they are angulating it to 45 degrees, sir.
Yes. That is one technique. Another technique, if you are more experienced, instead of doing that, you can do at a 45-degree angle. Straight away go and puncture the sacrococcygeal membrane, which is identified by, how do you identify that you have punctured the sacrococcygeal membrane?
So
Lots
giveaway
of this.
will
It's
have a
called the pop.
give
You will
pop.
get a giveaway field. Okay, and once you get that giveaway field at 45-degree angle, what should you do? Will you enter at the same 45-degree angle?
No, sir, we have to make the needle light parallel to the skin and then
You must keep it flush with the skin. That is 0 degree. So from 45-degree, once you have entered the sacrococcygeal membrane, once you feel that pop or giveaway feeling, you bend the needle to parallel to the skin or at 0 degree angle and slightly advance it. You should not advance the entire needle. You should advance it only a little bit. Why? Why can't you inject, push the needle up to the hub? What gauge needle you will use for a caudal block?
sir,
23
24
or 25?
atomic needle.
22 or 25. 25 is too small. Okay, you will not miss the pop feeling. You must have a blunt 22 gauge needle, which will give the pop feeling. And once you enter the sacrococcygeal membrane, advance it just by 1 millimeter or 2 millimeter, not more than that. Because if you push the entire 1.5 inches of the needle, sometimes you may puncture the dura, because the dural sac is quite low in the babies. So you may puncture the dura and make a total spinal. So you should not push the needle too much inside. So how do you further identify that you are in the space?
So we have to do check aspiration.
You can do a check aspiration for CSF or blood, and you can also push air to see whether the air is going freely, just like you are identifying the epidural in the lumbar space. You should have no resistance to the air. 1 or 2 ml of air can be pushed into the space, so that you see whether there is any resistance or any bulge. If you are subcutaneous, there will be a bulge in the skin, because the air will be entering the subcutaneous tissue, and you can palpate the crepitus there. So that is the method of identifying, and then you can calculate and give the dose 0.5 ml per kg of 0.25% bupivacaine or levobupivacaine can be injected and do that. So this is the preferred method of anesthesia. The other options, what are the other options for circumcision surgery?
So penile block or ring blocks?
Penile block. What are the methods of giving penile block?
Sir, initially we have to inject at the pubic symphysis, then we have to walk below the pubic symphysis, and we have to inject the local anesthetics laterally.
What nerve you are planning to block if you give a penile block? What are all the nerves to be blocked when you give a penile block? Every question when they ask about the block, you must say the nerves that you want to block are the nerves supplying the sensory segment to that particular organ. So what are the sensory nerves supplying the penile shaft? It is called the dorsal nerve of the penis. Is it a single nerve or a double nerve? See, these are all the anatomy you must learn. Just by saying penile block, you cannot escape in the exam. They will ask you all the questions. Okay? So penile dot, there are two. It's a pair of nerves. Dorsal nerve of penis is a pair of nerves, right and left. So that can be blocked by the dorsal nerve of penis. Which fascia you will have to pierce to block this nerve? What is the
Buck's
fascia
fascia.
covering the dorsal nerve of the penis?
Buck's fascia, sir.
Buck's fascia, correct. B-U-C-K-S, Buck's fascia. So you can block it by identifying the pubic symphysis, putting your left finger, index finger there, and then just 1 millimeter below that, you puncture the skin at 90 degrees. All the time when they ask you about the block, you remember 4 P's: position, palpation, puncture, first preparation, position, preparation, palpation, puncture. Okay. So the puncture is at 90 degrees. Again, here when you pierce the Buck's fascia, you will get that pop feeling or giveaway feeling. And then inject about 1 ml or 1.5 ml there. Some people inject at the right and left separately, or you can inject at the midpoint a larger volume, 3 ml, which will cover both that. This will mostly take care of the dorsal surface, because it is called dorsal nerve of the penis. It will take care of the dorsal skin. But the frenular area, the ventral area, may sometimes be not adequately blocked if you give the dorsal nerve of penis block alone. So how do you block that ventral area? And what nerve supplies that area? The ventral area is supplied by the genital branch of the genitofemoral nerve. Okay. The dorsal aspect is supplied by the dorsal nerve of penis. The ventral surface is supplied by the genital branch of the genitofemoral nerve. And that can be blocked by injecting 1 to 1.5 ml of local anesthetic subcutaneously at the root of the penis on the ventral aspect, where the penis joins the scrotal sac. You will have a median raphe. So you just inject 1 ml on either side of the median raphe on the ventral side. That will take care of the frenular or the ventral aspect also. So this will be the method of blocking the penile shaft by what is called the penile block. Okay, and of course these blocks can be supplemented with the inhalation agent. You can just hold the mask with an oxygen nitrous oxide and either sevoflurane or isoflurane for the entire procedure, and keep the baby quiet for the whole surgery. Okay, so this is the second option, and the supplemental GA is the third option. As far as possible, as rightly said, avoid laryngoscopy and endotracheal intubation, because the child has recently recovered from LRI. Our goal is to avoid irritating that. So if GA is preferred, what is the precaution? Again, that is the question. And caudal epidural space anatomy, you have to know why caudal block is not chosen for adults. What is the answer for this question?
So it will be fused. It will be fused in adults.
Which one? Which is fused in adults? You mean the sacrosis hiatus is not there? Is it fused?
Fused. It is the unfused.
See, first of all, there is a lot of fat in adult. Identifying the sacral conva and the sacral hiatus is technically difficult, number one. Number two, the holes in the sacral canal. The sacrum is nothing but the fusion of all the 5 sacral bones. The foraminal space is very large, and whatever drug you give in the caudal epidural will all ooze out. So you have to give a larger volume, and the effect is inconsistent. And that is the reason why caudal block is not very popular in adults. Okay. So that is all the questions and answers that we have to face for this particular first topic.